Case presentations, room 4.
Okay. Our first case is a 38-year-old gentleman who's a chronic smoker and an ex-heavy drinker. He has a history of ketamine and amphetamine abuse and a past medical history of chronic pancreatitis since 2015. He presented with on and off epigastric pain requiring analgesia, and his MRCP showed chronic pancreatitis changes with marked pancreatic duodenal dilatation, ductal dilatation, diffuse pancreatic atrophy, and probable obstructive stone of 7 millimeters at the pancreatic head, mildly dilated CBD with smooth inferior tapering and no intraductal stone. This is the MRCP imaging of the pancreatic stone. And today we'll perform an ERCP plus pancreatoscopy and laser lithotripsy performed by Professor Beyna.
Hello, Professor Beyna. Hi, how are you? Good afternoon.
Good afternoon to everybody. So first of all, I would like to say thank you for inviting me for the first time to come to this outstanding and a workshop with such a long tradition. So it's a great honor for me to be here, and it's also a great honor to work together with this amazing team with Wai and Sheila and the entire team in the room. And today I have the honor to work under the supervision of one of the great masters of ERCP in the world with Reddy. So thank you for being with me here. So let's have a look at our case. So you have seen the MRCP, so it's, I think it's mandatory to know everything about the anatomy beforehand. So we have MRCP, you have seen we have a nicely dilated main pancreatic duct, and we see this filling defect at the level of the papilla, very close to the papilla. So this is why we discussed it may be difficult to perform pancreatoscopy in this case. However, let's give it a try. We can nicely see here, and I hope you can see this as well, the papilla. We have the patient here in the supine position because the patient is intubated. What makes the positioning in front of the papilla a little bit more difficult, you see, I have this very nice endoscope, the Olympus TGF Q290 here in my hand, a little bit torqued, so that I have a good position here in front of the papilla. We see this bulging of the papilla quite nicely, and beforehand we took an X-ray of the patient's abdomen. I think you can see it as well. So we were discussing if we could see a radiopaque stone here, and we might, discussed we might see this stone in front of the spine. Yes. Yeah, maybe you can see it on the X-ray overview as well.
Are you getting the fluoroscopy picture? If you're getting the fluoroscopy picture, you can probably see that shadow there, which appears to be on the spine.
Yeah. So in front of the spine, huh? Maybe it's there. So it will be difficult. So
it's a little bit weak for us.
Our plan is now that first the patient has not received ERCP yet. So first is that we have to cannulate the pancreatic duct, and then the second challenge is to pass the guide wire alongside. So and then after pancreatic sphincterotomy, the best we can achieve would be that we can at least decompress the duct upstream of the stone here. So we have chosen here a combination of sphincterotome. We have here the Olympus clever cut sphincterotome together with a straight 025 Visiglide guide wire with a straight tip and hydrophilic coating. So please advance the wire just a little bit, that we have it at the level of the tip of the instrument already. Okay, it's here, so then go back. So we have given some Buscopan here, and we can now inspect the papilla. So it's now very calm condition, so we try here to cannulate. Yeah, so it seems to be that we are here in. So please do not bend, no bending right now. So I turn the scope a little bit using the small wheel into the direction of the main pancreatic duct. So please try to advance the guide wire.
It's a very nice demonstration by Torsten of how he's inserting the papillotome and then rotating the scope.
Stop, no.
And then rotating the scope so that you can see very nicely.
I push a little bit here forward.
Yeah.
We can go into the pancreatic direction. Please try again. Please try again to cannulate. We have some resistance here.
So that's where the shadow
maybe
is,
we're
at the stone level.
Yeah, we are at the level of the stone.
Yeah.
So here, at this level, okay, I push now the scope a little bit forward to get in the position from below. Okay, maybe you can try again to cannulate with the wire, advance the wire. So I think we are at the level of the stone. Okay, at that point I would like you to inject a little bit of contrast that we can. Okay.
So this is impacted right at the stone there.
Okay, pull back the wire, please. Pull back the wire. And now, okay, now give a little bit of contrast.
Yeah, it's going down.
It's going down here. You can see.
Very nice.
Okay. Okay, we take a picture.
And then probably you have to pull back.
We can pull back a little bit, and I again. So we turn the small wheel that we can adjust a little bit the tip of the sphincterotome into the direction of the duct that we see in front of us. So I pull back, and now please try to advance the wire again. I turn the scope.
Very nice.
I pull back. Very good.
Nice.
So, please leave the
I
guide
think
wire
that's a
there.
side branch there.
Maybe that's a side branch there. But now, okay, push. Now we go down, then pull back, pull back, and now we give a little bit more contrast here.
That's the stone there.
Okay, that.
Yeah.
We have the side branch here.
Yeah, and then it's turning around and then going to the stone there. Yeah, very nice. Beautiful demonstration.
Okay, and then we try again now.
It seems that there's a sharp bend.
Now try to push.
That's a.
Try to push a little bit.
Yeah. So you can see that the pancreatic duct is curving to a side, and then the stone is right at the curve there.
So it's difficult
very
here.
Very difficult.
So leave the guide wire where it is. So first I would like to perform a small sphincterotomy of the pancreatic part of the sphincter. So we are obviously in a good position.
Yeah.
So please connect the sphincterotome.
I think again, not to be pessimistic, Torsten, I think this is a very kinked duct. So difficult to put in a pancreatoscope, I think.
So here we are using the Olympus ESG 300 electrosurgical unit. So we connect here, and we then choose an alternate cutting with less coagulation with an effect of 2. Okay.
So you'd use a different cutting then compared to bile duct, you know?
Less coagulation here. So, did you connect?
Some people use pure cutting, but I think this is a good idea to have some coagulation.
At least some, huh?
Yeah.
Okay. Then push the wire, please. Push the wire a little bit forward. Okay, because I have to pull back the sphincterotome just a little bit. Leave the wire there.
Yeah.
Now I release a little bit the large wheel to go back. Okay, then you can bend a little bit the sphincterotome, just a little bit. Okay, that's good, not more. Okay, and I use here my right hand at the level of the shaft of the endoscope. I do not touch the sphincterotome itself, so we can.
Controlling. And you can see the
very
direction
nicely,
is what, 1 o'clock.
Into the 1 o'clock direction in a very controlled way of cutting. I think one more cut is enough. Okay.
Yeah.
Okay, that's enough. Then you can release the bending.
Straighten, yeah.
And we straighten again. So let's see what we can achieve here. So we are now again in the deep in the duct.
Yeah.
Maybe please try to push forward again. the wire. If we can pass here alongside.
Is there resistance?
There's high resistance.
Yeah.
Okay, push. Try to push. High resistance. Yeah. Push a little bit. Okay, now we are in the side branch again. I try to follow you with the sphincterotome. So let's give some more contrast at that point. Huh? Yeah. That would make sense, huh? From here.
Yeah,
It's coming out here. So I go back a little bit.
But I think this is, the stone is impacted there at the angle. So it's going to be difficult.
It's very difficult to pass, huh?
So you have an angled Visiclite?
Yeah.
Maybe
We're changing now to an angled wire. Yeah, there, please pull it out. Yeah, thank you.
And I think, Torsten, even a pancreatoscope won't go through that bend. It's bent there completely.
This is usually the problem.
So, yeah.
Even if we can advance this, the scope into the duct, we cannot really target the stone, no? Because we have to cross this bending.
What we would ideally do in this situation is to subject the patient to extracorporeal shock wave and then fragment these stones.
Okay, you are here.
Yeah.
So please try again. So
you can see some proteinous particles coming out from that. Yeah.
So I try to a little bit adjust here the angle. I go back to give you more space for manipulating the guide wire. That's not easy right now.
No.
So I just go back a little bit.
Professor Beyna, some people would advocate to use ESWL before the ERCP.
Definitely.
What would you think? You would like to go for direct pancreatogram and stone extraction, or just do the ESWL before the ERCP?
So this is a good indication. So at least in our country we have less access to ESWL facilities. So in many hospitals we have no effective machines available, and we know very well that the results of ESWL, for example in India or in Belgium, in Brussels for example, are very good. And this is something we cannot always see in our country. So,
but this would ideally, I think, go for a ESWL.
Yeah.
You can fragment the stones. The duct will then straighten a little, and then rest of the therapy becomes easy.
I think this is the way to go.
In India, you will do the ESWL first, or you do the ERCP first?
First the ESWL, you don't do the ERCP. In a case like this, after the MRCP, the patient will go for ESWL, and then we do the first ERCP after the ESWL, because then you can clear everything by that time.
So this is this sharp bending there. You can always see the wire bends a lot, and it's very difficult here to manipulate. And if you have to pass this tight stricture that is caused by impacted stone behind this bending, that's more or less impossible.
If it was a straighter duct, you could have gone through and then used a Sohendra to crush the stone. But I think this is not possible now. It's angled completely.
Yeah.
And it tends to go
so where
to
does
side
it go
branch.
now? So
it's going side branch.
Yeah.
That's a side branch.
That's the side branch, definitely. So what we can try is that I follow you as far as I can and try to bend the sphincterotome just a little bit into the. I think we can go into the direction of the bending. So pull back the wire, and then you can bend the sphincterotome just a little bit. Okay. So welcome back. So we have made some progress. Unfortunately, we did not succeed in passing the stone. So we have seen, and you were with us when we realized that we have the stone that totally blocked the duct upstream of the stone. And so we injected contrast. No contrast is going across the stone. And the stone is located at the genu of the pancreas, directly behind this very sharp bending. And so we tried with different guide wires. We changed to an angle tip hydrophilic guide wire. We even used the bending of the sphincterotome. So all of us together, we came to the decision that at that point it makes no sense to further try to pass the stone, because the chance of succeeding is very low. And even if we were able to pass a very thin guide wire, so the consequence would be that maybe we would not be able to pass an instrument. So in case we would have a straight position and put a guide wire alongside, we could have used a balloon or even a Sohendra stent retriever to drill us through the stone. But here in this case, it would be too risky. And the second option would have been to put in here the pancreatoscope, so the for example, the spyglass or the IMAX scope that is available right now. But we can also anticipate that we cannot visualize the stone because it is located behind this very sharp banding. So at that point, we have 3 different options. So we could go for percutaneous therapy, ESWL. So we discussed this is also difficult to get. Second option would be, and this is, as Nagi told us correctly, it would only be a temporary treatment if we try to do an EOS-guided drainage of the main pancreatic duct. That could be possible technically, but then it's very unlikely that we can pass in an antegrade fashion into the duodenum because of the impacted stone, and then the next option would be to send the patient to surgery, of course.
I think surgery in a young patient like this, with a large impacted stone and dilated duct, is very easy for surgeons to tackle.
And also it is very difficult for the ESWL to identify this relatively radiolucent stone. We can see it very clearly here.
Maybe we can see it in front of the spine, but still it's difficult to target. But this is one of the, as you said, for the surgeons, if you have a dilated pancreatic duct, then it's easier to do the anastomosis. And here in this situation, the patient has a dilated bile duct as well. So this is a good reason to treat both ducts with one treatment.
Okay.
So unfortunately, we cannot present you the definite solution for this patient.
It's okay. So anyway, thank you very much for your demonstration.